Hello everyone, welcome to Dr. Sravani's Med Concepts. Adenosis of breast and hyperplasia will be considered as synonymous by most of us. In today's session, I tried to explain the adenosis of breast and how to differentiate it from various forms of hyperplasia in a simpler way, and you will have case-based discussion in the end for practice. As per WHO classification 5th edition, under epithelial tumors of the breast, we have benign epithelial proliferation and precursor lesions, under which we have usual ductal hyperplasia, flat epithelial atypia, and atypical ductal hyperplasia. All of this has been discussed in the previous sessions. Today we'll be dealing with adenosis and benign sclerosing lesions. In adenosis, we'll have sclerosing adenosis, apocrine adenosis and adenoma, microglandular adenosis. In benign sclerosing lesions, radial scar and complex sclerosing lesion. Adenosis of the breast is defined as a relative increase in the number of acini or glandular units in the terminal duct lobular units. Under this, we have three entities, that is sclerosing adenosis, apocrine adenosis and microglandular adenosis. What is benign sclerosing lesion? These have a central sclerotic or elastotic nidus from which the glandular structures radiate. We have radial scar and complex sclerosing lesion under this category. As we can see here, so this is the terminal duct lobular unit, which is normal, consisting of terminal duct and lobule filled with the acini. So here this is a histopathological diagram of breast showing multiple lobules. So all of these are lobules, okay, all these are lobules, and this is the extralobular duct, and this will be the terminal duct, okay. So from here, this is known as the terminal duct lobular unit. So this is a lobule filled with acini. So as we can see here, there are a number of acini. So each acini is lined by double layered lining, that is inner luminal epithelial cells and outer myoepithelial cells. But in adenosis, now what is happening? So the terminal duct lobular unit, there is expansion of the lobule, that is because of acini. So as we can see here, so here is this is the lobule consisting of acini, and this lobule, what has happened here, there is expansion of the lobule because of increase in the number of acini. So but the lining of the acini remains the same, the double layered lining remains the same, but the number of acini has increased. Okay, so there is increase in the number of acini per lobule. That is adenosis. So acini are lined by normal two-cell population, that is luminal epithelial cells and outer myoepithelial cells with intact basement membrane in case of adenosis. So here it is IHC of smooth muscle myosin heavy chain, which shows intact myoepithelial cells at the outer rim of each acini. Coming to the microscopy of adenosis, there is lobulocentric pattern, which is the classical feature of any adenosis. That means the proliferation remains confined within the lobules and the lobular unit appears enlarged and it maintains its overall architecture, and there is increased number of acini, because of which the lobule contains more acini than normal, and there is dual cell layer lining consisting of luminal epithelial cells, myoepithelial cells, which are preserved and seen and demonstrated with smooth muscle myosin heavy chain or P63 immunostains, and the stroma may be loose, fibrotic or sclerotic depending upon the subtype, like in sclerosing adenosis, and we can see calcifications also in case of adenosis. Coming to adenosis versus hyperplasia of the breast lesions, what is adenosis and what is hyperplasia? Most of us get confused between these two entities. Coming to adenosis, what is adenosis? It is increased in the number of acini per lobule, as we can see here. So in a lobule, the number of acini gets increased, but not the epithelial cells. In hyperplasia, what is happening? The number of acini remains constant, but there is increase in the number of epithelial cells within the ducts or lobules because of proliferation. So as we can see here, number of acini remains constant, but the epithelial cells within the acini or duct will get increased. So adenosis is increased number of glandular components or acini, and hyperplasia is increased number of epithelial cells. The same thing explained here. towards the left, you are able to see the normal breast tissue lobule with acini. In adenosis, there is increase in the number of acini, but the epithelial cells lining the acini is double layered only. So the number of acini per lobule are increased, and the epithelial cells lining the acini will be the same, that is inner luminal epithelial cells and outer myoepithelial cells. In case of hyperplasia, so it is atypical ductal hyperplasia. So here what is happening, acini per lobule remains the same, but the epithelial cells lining the ducts and acini in lobules will be increased in number. So in adenosis, acini are increased. In hyperplasia, acini are the same. And in adenosis, epithelial cells lining the acini will be similar to the normal conditions, that is double layered lining. But in hyperplasia, epithelial cells lining the acini or the ducts will be increased in number. So these are the contrasting features between adenosis and hyperplasia. What is adenosis? It is increase in the number of acini per lobule, and hyperplasia is increased epithelial cells within ducts or lobules, and the architecture pattern in case of adenosis is lobulocentric, and in hyperplasia there is intraluminal filling of epithelial cells in the form of bridging pattern, micropapillary pattern, and the type of adenosis or simple adenosis, sclerosing adenosis and microgranular adenosis. In hyperplasias you will have usual ductal hyperplasia, atypical ductal hyperplasia, atypical lobular hyperplasia. The cell population, it is dual cell population, inner luminal epithelial and outer myoepithelial cells. In case of hyperplasia, if it is usual ductal hyperplasia, there is increase in the number of epithelial as well as myoepithelial cells, giving heterogeneous population. In ADH or atypical ductal hyperplasia, it is monomorphic cell population. IHC pattern in case of adenosis, the myoepithelial cell layer is intact, which is demonstrated by smooth muscle myosin heavy chain and P63. And in hyperplasias also, myoepithelial cell layer is intact unless it is neoplastic. Malignancy risk in adenosis, there is slight increased risk, that is 1.5 to 2 times. In UDH, it is also slight, that is 1.5 to 2 times. But in ADH or ALH, it is moderate risk, that is 4 to 5 times increased risk of breast carcinoma. Adenosis may mimic invasive carcinoma even though it is a benign lesion. It has to be differentiated from carcinoma. In hyperplasia, it may mimic DCIS, especially atypical ductal hyperplasia. So this is adenosis. So in adenosis, what is happening? There is increase in the number of acini per lobule. In UDH, the acini remains the same, but the epithelial cells lining the ducts will be increased in number. In usual ductal hyperplasia, there will be heterogeneous cell population, there will be bridging, fenestrations, and secondary lumina will be formed, and there is streaming of the nuclei. In ADH, there will be monomorphic cell population, increase in each duct, and there is secondary lumina will be evenly spaced, giving cookie cutter pattern. So let us complete our discussion with few practice questions. A 35-year-old woman presents with a palpable breast lump. Microscopy shows enlarged lobular units with increased number of acini per lobule. The acini are lined by a dual epithelial myoepithelial cell layer, and myoepithelial markers highlight continuous outer cells. So there are so many things here highlighting that there is enlarged lobular units, means the lesion is pertinent only to the lobule, and there is increased number of acini per lobule. So when there is increased number of acini per lobule, it is adenosis, and it is demonstrated by double layered lining of each acini and highlighted by the myoepithelial markers like SMMHC or P63. So what is the most likely diagnosis? Is it usual ductal hyperplasia? No, because in usual ductal hyperplasia, what happens? The acini per lobule will not be increased, and the acini will be lined by multiple epithelial and myoepithelial cells, okay, giving heterogeneous cell population and mosaic pattern of IHC pattern. In sclerosing adenosis, it is characterized by the increased acini per lobule, and acini are lined by dual epithelial myoepithelial cell layers, and myoepithelial markers highlight the continuous outer cells. Okay, so the answer is sclerosing adenosis. Why is it not ADH or DCIS? Is the same reason, acini per lobule will not be increased. So lobulocentric proliferation with preserved myoepithelial cell layer is the characteristic feature of adenosis, and hyperplasia is characterized by intraluminal epithelial proliferation within ducts, and it is not characterized by the increased number of acini per lobule. Another question, Histological section of a breast biopsy shows proliferation of epithelial cells within the ducts forming irregular bridges, fenestrations and secondary lumina. The cell population is heterogeneous with streaming and overlapping of the nuclei. So what is the most likely diagnosis? Usual ductal hyperplasia, sclerosing adenosis, tubular carcinoma and microglandular adenosis. First of all, is it adenosis? Either it can be sclerosing or microglandular? No, because here it is not given that it is there is increased number of acini per lobule, so it is not adenosis. And in adenosis there will not be increased proliferation of epithelial cells within the ducts, so it is usual ductal hyperplasia, which is characterized by increased number of epithelial cells within the ducts with irregular bridges, fenestrations and secondary lumina formation, and the cell population will be heterogeneous with streaming and overlapping of the nuclei. It is not tubular carcinoma because no definite invasion is seen. Okay, so heterogeneous epithelial proliferation, bridging, streaming goes in favor of usual ductal hyperplasia, and adenosis means increase in the number of acini, and UDH increases means increase in the intraluminal epithelial cells. So with this we conclude the topic on adenosis of the breast versus hyperplasia. In the next session we'll move on to the sclerosing adenosis. I think this session had been useful to you. If you like, share and subscribe. Thank you.